This conference will now be recorded.
Okay, this is our January 11th, 2022 meeting of the Advanced Recurrent Prostate Cancer AnCan support call. And my name is Peter Kafka. I'll be moderating with the able assistance of Rick Davis, Herb Geller, Len Sierra, Ben Nathanson. Who am I missing? Anyway, we have quite a team. It's going to be a busy night. I'm just giving you a heads up. We'll try to get to everybody and keep it going. There's several new people. Actually, I had four lined up before we even started. Before I start, I want to introduce Alexa Jett. Alexa's joining our meeting. Many of you know Alexa one way or another. She's our invaluable right and left hand go-to person. She's one of our paid employees of AnCan and does just about everything. So she's invaluable and we sure appreciate her help. So she's sitting in tonight for whatever reason, and we welcome her anytime. Many of us are hugely indebted for her help, and I know Rick is, particularly in terms of assisting him in a multitude of projects. He could not continue without her help. So thank you, Alexa.
And we should add, Peter, that Alexa does moderate the active surveillance group. She's a co-moderator on the active surveillance group.
Okay.
And a special shout out, because we sort of breezed over it, but a special shout out to Ben Nathanson, who is our newest moderator, co-moderator, and we're all unanimously delighted to welcome him to the bench.
Okay. So Rick, how about we've got two of the new people on right now, and we're going to go to them quickly. But how about if you make your pitch for the study right off the bat, so doesn't get lost in the shuffle with people leaving later on. You want to do that?
We may have a few more people, so can I wait to do it after we're done with the new people and before we start with the
Sure.
with the questions?
Sure.
Thanks.
Just remind me. Okay. Ken or Larry Fish, do you have anything? Ken, Larry Fish, any updates?
Sorry, Peter, I'm driving, but I don't have anything.
Okay. Are you still coming over here on the 20th? Okay. What was the other thing I was going to say? Yeah, just spaced it out. A little bit of brain fog. Okay, so two new people we want to talk to. Well, maybe another one. Yeah. Daniel Ford. Is this your first time on the call?
Yes, it is. Yeah, it is.
Okay, and where are you from, Daniel?
Connecticut.
Okay.
Dan's in my Us Two group in Danbury.
Okay. Yeah, we'll see if we can get you in. Okay, let's start with Jeff Wood.
Peter, I've actually been here a few times. I really don't have anything to discuss tonight. I just appreciate the sharing, and I've been taking a lot of notes over the last 3 meetings and doing a lot of research on some of the terminology y'all throw around here, and just trying to educate myself. So I thanks to the group. I appreciate it.
Okay, I picked you because I thought Rick had mentioned that join us on Tuesday to discuss second opinions or so forth. Do you want to wait a little while and talk later on this?
Yeah, I mean, again, either next week or later on if there's time or something, but nothing to really to deal with right now. It's a good topic, though. I suppose it's something for everybody when you leave who you've started with, and when you move on. When's that a good time?
Okay, we'll try to come back to you. Okay, Chick, welcome again. This is your third meeting in a week, I think.
Yes, I think it is.
Yeah. Okay,
But,
we don't want to make light of it. Chick was on our call last night, or low and intermediate, and he was also on a call earlier in the week or last week for active surveillance. So he's moved up the ladder quickly. Chick lives in Wisconsin, pretty close to the Minnesota border. He's a young man, and he had surgery, right, at Mayo? Is that correct?
Yes, that's correct. Rochester, Mayo.
Right.
2 years ago. 2 years ago this month.
Right. So now he's dealing with some recurrence, and that's why he's here. And we talked a little bit with him last night, and what he's thinking of doing is he's not happy with the help he's getting in Rochester in Mayo, and he's thinking of perhaps looking at this point for an oncologist, and he's not too far from the Minneapolis area or Mayo, but he's even closer to Minneapolis, even though he lives in Wisconsin. So are you near Lake Pepin?
About maybe 30 miles.
Okay.
Yeah, beautiful.
Okay, so without going into all the details, how old are you, Chick?
I'm 68. I also have a brother who is 75 and also now 12 years past his prostatectomy, also at Rochester, Mayo. And about 6 years ago went through some radiation, 30 some bouts of some kind of radiation at Rochester. And now he's at a point where the PSA is also rising, and he's looking at some hormone ablation. But it looks like right now that's not going to happen for a short term. So anyway, I'm 6 years, some 10 years after 9 years after his surgery, I had surgery. Anyway, so then 2 years ago was that surgery for me. And now I have this biochemical recurrence. And so listening to the forums here, listening to AnCan, much like Jeff over the last, say, 4 or 5 weeks, for the first, I just recently became aware of AnCan. I'm listening to your forums. I'm aware that there are other treatment modalities besides, or I knew nothing about chemotherapy. I knew nothing about BRCA1 or BRCA2 and germline testing. And so I'm just trying to educate myself for sure about that. And also trying to wonder, what is likely, what is the next step for me? I have communicated via the Mayo portal with, some residents. It's always been residents over the last 2 years. Newly minted urologists, and most recent conversation or by email the last couple of days was, I don't have it here, I could pull it up, but the comments, she said there is no germline testing indicated it has no role in your treatment at this point right now, and that if in the end of March, should my PSA come with a consecutive threshold point of 0.20, then I will need to have an MRI prostate. That's what they'll recommend, and also a PSMA, a PET test, a PET PSMA test. That's what the email said back to me.
Right. And as we discussed last night, probably almost everybody on this call tonight would chime in and say you really should get at least germline testing at this point, particularly if you've got a brother ahead of you in the game with prostate cancer. If you got one brother like that, it's almost essential to do it. And I'm surprised that they didn't say it was necessary at Mayo, but almost everybody on this call would say go do it, and maybe even further testing, because you don't know. It's just too coincidental and too many a little too strange that both you and your brother have it.
Sorry.
Okay, and also you were diagnosed at 66. That's kind of right on the right in the target. That's the average age for people. And you're 4+3, and your PSA is rising. It's what'd you say? It's 0.2 now. It's gone up to 0.2.
Yeah, yes, a month ago, 0.2.
So I'm gonna open it up. I'm sure Rick has a comment, but since you're so close to Minneapolis, the logical thing to do is one of the best world-class Genito urinary medical oncologists in the U.S. is there. He recently moved there from Hopkins. His name is Dr. Antonarakis. And I'm sure other
From where?
people. He was at Johns Hopkins for years.
Oh, okay.
And now he's at the university in Minneapolis.
What? University of Minnesota. What's his name?
Antonarakis. Somebody will put it in the chat window. But let me throw it open to other people to comment on Chick's situation. What you would do if you were in this situation? Would you shift gears and go with a medical oncologist? Would you stay with Mayo? What's your feelings, guys?
I have no doubt I would go to Antonarakis at this point.
Who's saying that?
Me, Herb Geller.
Herb. Okay, thank you. Antonarakis. Okay,
I mean, he has an outstanding reputation as both a clinician and a researcher, and his patients really like him. And I think you're lucky that he, we lost him in our area and you gained him.
Okay, thank you for that.
But I think, I mean, in other senses, I don't think a urologist is the right person at this point.
Yeah, I kind of. So go ahead. Yeah.
You need a medical oncologist.
Yeah. So does everybody know how to use the chat window? Chick, do you know how to use the chat window?
Yes, I do. Thank you. I'm seeing it right now.
Okay, so we put it in. I put it in there. I think that maybe Les should say something here because Les is being treated at Mayo. If it were me, I would definitely want to see at this point a GU medical oncologist. As I said to you, Chick, when I wrote to you, if you can tell us the cities that you would consider, then we can come up with names. I think the two names at Masonic at University of Minnesota would be either Emanuel Antonarakis or Chuck Ryan. Chuck is still Chuck just took over as president of PCF, Prostate Cancer Foundation, but he's still seeing patients. I don't know if he's taking new patients. Probably not, but that's not for certain. And then if you would prefer to go to Chicago or some other location, we could probably come up with names for you there too.
Thank you. Madison, Wisconsin, anywhere on the east side of Wisconsin would be of interest to me. Also, Iowa, perhaps Iowa might be a place, but
yeah, Iowa, we really don't have anybody, but we do. Lang, isn't that Dennis? Isn't Dennis McGuire? Isn't that who you see?
Yeah, that's right.
Joshua Lang.
Yeah, Joshua Lang at the Carbone Cancer Center in Madison.
And there's another guy other than Joshua Lang. I've got to look up his name.
Yeah,
I'll give it to you.
Glenn Liu, L-I-U.
Yeah, that's it, Glenn Liu. He's also good. Who do you have can you give any guidance on that, Dennis?
Yeah, I would definitely recommend Josh Lang if you're interested in Wisconsin. I can put my phone number in the chat window if you want to talk about it.
Thank you. That'd be great if you would. I appreciate that.
Sure, I'll do that.
All right, thanks a lot.
Hey, I got pulled away for a second, but I will say one thing to check about genetic testing. When it came up for me on this group and we were talking about it, a lot of people talk about going back to their urologist or oncologist or whatever. I went to my primary care doctor and said that, the history in my family, and she said, sure, it's medically necessary. So she was the one that actually ordered my genetic testing. It didn't have anything to do with who was the people that were treating my prostate cancer at the time. So that might be a different route in case people don't think about that. Once you move past your primary care doctor and you're seeing all these specialists, don't leave them out in the cold because they're still there.
Thank you. I hear what you're saying, and thanks. I've changed primary doctor. He retired, but there is another individual urologist that actually did my biopsy, and so I think maybe I would perhaps talk to him. This is not a fellow in Rochester, but in Eau Claire actually. But so just if I could just ask one other question, the germline testing. So what does it reveal? That if it should, what does it reveal, and then how does it impact the actual treatment path?
Well, so other people can speak to it. I think about 12 or 16% of us with prostate cancer actually have a genetic mutation, a known genetic mutation that probably is driving our cancer. I'm one of them. And of those, there are certain genes that have been, that science has figured out that are prone to drive prostate cancer. The most well-known ones are the BRCA1 and BRCA2 mutations, and about 6% of that 16% of guys have a BRCA mutation. So it's not only just breast cancer; it's prostate cancer as well that can drive it. And because of that, there are targeted therapies that can help manage that disease if you know up front or along the way that's what's driving your cancer. There might be some unknown genes, but most of the companies that test have a panel of usually over 100, 160, whatever different genes that they test for, and see if you have a mutation along those lines. So somebody else would probably want to explain a little further.
Is there any breast cancer in your family for the women?
Because if there is, that's a big indicator that it's a BRCA problem.
I'm not aware of any. My grandma had a cervical cancer. I was my understanding. But breast cancer, not that I'm aware of. Believe me, I'll be asking my sisters to see if they know of any, if they're aware of any.
Yeah, you don't want to try to guess this. I mean, the test is very simple. It's usually starts off with either a blood test or a mouth swab. It's very quick, very easy, and you'll get the results pretty quickly, and go from there. I mean, this is a very non-invasive test. It's kind of like getting. It's just a no-brainer. I'm surprised
Sure.
that Mayo is holding up on this one.
Yeah,
It doesn't make sense.
It's an easier test than a COVID test.
Okay.
Right.
Oh.
Yeah.
So when they talk about the intervention, then
I'll agree with that.
So let's say I have the BRCA mutation. Does that then the interventions that come from that the treatments, is it like a chemotherapy kind of treatment, or is it a certain kind of radiation kind of treatment, or something else?
It really depends. It depends very much on what the mutation is. There are different, according to the mutation, there may be different infused chemotherapies. There may be different oral chemotherapies. There may be certain immunotherapies. There's no simple answer to that. But what we know, you've probably heard over the last 10 years or so talking about precision medicine. What is precision medicine? It is trying to find your most exact disease demographics so that we can match the best medicines to this. And this is part of precision medicine. And we can't tell you what the precise treatment might be, if any, until we know what there are, but just be aware that by honing down on your own personal genetic profile, we may be able to improve the treatment if there's something in there. A lot of times there's nothing actionable.
I see.
For a few people there are, and if there is something actionable, it may be employed, maybe not right away, you'd still be on the normal path, but if it recurs again, then maybe down the road there would be a change. So it's not a magic bullet, it's not a silver bullet by any means, but it certainly helps. And this is why it's a puzzlement to all of us here, why an institution reputation of Mayo wouldn't even want to give you a germline test when you have a brother who has prostate cancer. It doesn't make sense to. It doesn't make sense to me personally. I suspect it doesn't make sense to a lot of people on the call right now.
Right. So you check. You don't want to get ahead of yourself guessing on this stuff. What you want to do is find a Genito urinary medical oncologist who will be your quarterback, who will guide you in this thing. They're not going to be a surgeon. They're not going to be a radiation oncologist. They will make suggestions on treatment, further treatment if it's needed, and they'll certainly guide you to genetic testing and any other kind of testing or scans that you might need. And you don't need to visit them every 3 months or 6 months. I mean, once you have an initial visit, you could probably just deal with them on the phone or online or however they choose to meet with you. You know, they don't necessarily need to feel your glands and check you out anyway, but they want to track you and they're going to be with you for a long time. You're going to be managing this disease for quite a while. And so you want someone who's going to be around and easy to reach and someone you can trust and work with. And it doesn't sound like you're getting that kind of attention in Mayo. So I would focus on that first. And if you want to come up, once you land on someone and make an appointment, if you want to come up with us with how to help you out with questions to ask, we'd be glad to do that. Does that make sense?
It sure does. It really does. Thank you. Mayo right away in the last email, the same respondent resident said, likely the next part of this will be if the test shows there's a spot or something that would go right to radiation. And that was also just like, well, okay, from listening to you guys, it sounds like I'm not sure it should be that simple. I mean, maybe it is that simple, but also maybe like you're saying, there's other.
Chick, let's not get ahead of ourselves.
Yeah,
Let's
okay.
first of all see where you are and settle on where you want to get your treatment. I do feel like in defense of Mayo, we need to give Les the opportunity to take the floor if he would like to. Les, is there anything that you would want to say? Are you there, Les?
Over there, I think on top of the dresser.
He was. I don't see him now.
I see him, but I don't see his microphone
Oh, there
on.
he is. Yeah, there he is. I see
He
him.
must have stepped away. Calling Les once or twice. No. Okay, we need to move on. So there you go. Anyone else? Anybody else have anything they want to add? Okay.
Thank you.
So Peter, before we move on, we have a caller 02. Can you identify yourself?
Greenfield.
Jimmy G.
Jimmy Greenfield.
Jimmy G.
Oh, Jimmy. Okay,
Yeah, yeah.
Jimmy. Miss your face.
Yeah, my face will come back. I know you missed my face.
Put it in. We'll put you in, Jimmy. We got you covered.
I'm just here.
Okay.
Okay. I think that's right now the only. Oh no, Daniel Ford, you're a new person too. Before I move to you, Daniel, I just want to ask a general question because I don't see Jake on here. And has anybody talked to Jake recently?
No, but I think we better write him an email.
Right.
I saw Jake. I saw Jake's tag on the call last night, but he didn't talk.
Right.
I
Anyway,
sent him an email today, but I haven't heard back yet. This is John.
Okay. Well, yeah. Well, if anybody makes contact with him, I'll try to call him later too and see. But I don't want to call him too late. But although he's a night owl, yeah, because we're all thinking about him for sure. Okay. Okay. Daniel Ford.
Yeah.
So tell us about yourself. I'm going to ask you a few questions here, just so we can all get on the same page. How old are you, Daniel?
59.
Okay.
And
where do you live in? You live in Connecticut, correct?
Yeah, Connecticut.
Okay. And when were you first diagnosed?
2 years ago.
Okay. And what was your diagnosis? What was your Gleason score and so forth?
Gleason 9, with extracapular extension and gross bladder neck invasion and seminal vesicle invasion. And so our initial urologist was recommending, RP, and we got a second opinion at Sloan, and they thought radiation would be better. So we went that route. So we started ADT right away, and it wasn't until September that I got brachytherapy in Manhattan, followed a month later by 25 rounds of beam radiation. So just had my last Lupron shot in December, so wrapping up 2 years of ADT, and now it's just the waiting game and hoping that it doesn't recur. And in the meantime, since my diagnosis, we've made a lot of lifestyle changes to hopefully optimize my overall wellness and give myself the best chance of fighting this thing off once the ADT wears off. So that's kind of where I'm at right now.
So are you dealing with a medical oncologist or just a radiation oncologist?
No, both.
You've got both.
I've been on,
Both
I've been
MSK?
on, I've been on Zytiga, prednisone,
Okay.
and monitoring liver function as we go. And I ended up on a 750 milligram dosage that was stable. At 1,000, my liver enzymes were getting out of whack. But
What about scans? Besides the extracapular, the seminal vesicles and so forth, was there any indication anything was in the bones or the lymph nodes or anything?
No, I mean there was one suspicious lymph node. Not really anything they could determine. No evidence of Mets.
Was the lymph node in the prostate bed area or was it further in the body?
Yeah.
Okay.
And it could have just been an inflammation from the biopsy procedure.
Right. And the brachytherapy you did, was that permanent seeds or
no, high dose radiation where they put them in and take them out.
Okay.
So basically we threw the kitchen sink at it, and I've been throwing the kitchen sink at it lifestyle wise. I've gone vegan, cut out alcohol, sugar, salt, oil, processed foods, exercise vigorously every day, meditation, basically everything we could think of.
Did MSK put you through genetic testing?
Yeah. And I have no BRCA mutations, or I have loss of P10, which is pretty common, I understand. But I'm not aware that anything in my genetic profile is actionable. We also got a test by a company called Tempus. I think they're out in Washington, which initially I wasn't going to do, but then they kind of went ahead and did it anyway. So I have that result. Not really sure what value that provides, but we're going to.
Yeah, I think that Tempus test, it's either an RNA test or some other type of transcription, which I'm familiar with people that have done it, but I don't know much about it. Anybody know about anybody else on the call know about the Tempus test? I know that Brian McCloskey has mentioned it a couple of times. Guess not. We need to know more about it. But it might be an RNA test.
I mean, they billed my insurance company $8,000 for it. And I wasn't sure whether they were going to pay for it or not, so I wasn't going to do it. But then they kind of just went ahead and got the biopsy sample and ran the test anyway, and insurance paid, so all good.
So you must have pretty good insurance.
Yeah, Cigna insurance through my employer.
Okay, that's good.
Who's your medical team at Memorial Sloan Kettering, Daniel?
Philip Gilbo is my radiation oncologist, and he recently became the chief of radiation oncology at Norwalk Hospital, which is where my medical onc is. So I still have a foot in the door at Sloan if I need it, but both of my docs are at Norwalk now. And the reason I ended up with a medical onc at Norwalk instead of Sloan is because I needed somebody who was also a hematologist, because I had an issue with a kidney stone, which upon X-ray revealed a pulmonary embolism. So I needed somebody to put me on blood thinners while they, and then they had to put in a stent in and then do lithotripsy to get the stones dealt with.
Right.
So that was fun last year. Actually, that was 2020. That was all 2020.
Do you not have a do you not have a GU medical oncologist right now?
No, I do. I have a regular urologist who did the kidney stone stuff and who I go to for Lupron. And then I have my medical oncologist at Norwalk who monitors the Zytiga and, we'll be monitoring my PSMA going forward.
Do you have a Genito urinary medical oncologist?
I'm not sure the distinction. I mean, I have.
So let us help you. A Genito urinary medical oncologist is a medical oncologist like your guy at Norwalk, but they specialize solely in genitourinary cancers that include prostate cancer. And our recommendation is that you really need one on your medical team, especially if you have complicated prostate cancer as you do. There are a lot of reasons why, as we said to Chick, you don't need to see him all the time, but there should be somebody, say at Memorial Sloan Kettering or at Mount Sinai or at Weill Cornell, who's a GU medical oncologist who's following your case. Was there ever a GU medical oncologist assigned to you at Memorial Sloan Kettering when you were seeing Gilbo?
I had a medical oncologist there who I can, follow up with if I need to. Whether he was a GU medical oncologist, I don't know.
Probably was. Do you recall his name?
Min Teo, T-E-O, is his name?
Yeah, I don't think so. I mean, we would say, get yourself with somebody like Dana Rathkopf is a good example. She's outstanding, compassionate. It's tough to see Howard Scher. It's tough to get into Michael Morris. Michael Morris is another great option, but these are the sort.
We're also working with a guy named Den in Johns Hopkins.
Yeah, we know him well.
I don't know if he's GU medical.
And he's a GU. He is a GU medical oncologist.
So
he's done. You might want to look. You might want to put Den in the search box on AnCan because he did a presentation for us on BAT about 3 or 4 years ago. We've had a number of people who have seen him. He's good. But our take is he's a bit of a one-track pony. He tries to sort of move everybody into some sort of BAT related, and sometimes it's appropriate and sometimes it isn't.
How do you know whether it's appropriate or not when you've tried other things that didn't work?
Well, you kind of know. First of all, we have some anecdotal experience of people who have done it. And secondly, and there's been some very recent studies, which maybe Len or Herb can maybe more familiar with, where there's some idea that doing BAT in between abiraterone can revigorate the androgen receptors, and so there can be an impact there, but it's not really clear. The evidence is murky. For me, he wouldn't be my. I would see him, and we've had a lot of guys who have just been to see him for BAT. He wouldn't be my doc of choice. My doc of choice probably would be somebody from out of either Memorial Sloan Kettering, Mount Sinai, or Weill Cornell, or New York Presbyterian, one of those four.
So your take is that somebody who's a GU medical onc is more up on the latest and greatest studies and
right.
Exactly.
There's Dan, there's just too much oncology going on. Every day you get showered by new updates in different areas, and there's no one person who can really keep up with this stuff. So that's why a specialist in GU is really essential when you've got a Gleason 9.
Right. Len, do you have any comments? Because you said you've either met Daniel or you're aware of Daniel because you're both in
Yeah.
Connecticut.
Well, Dan joined our group when he was first diagnosed, and then he kind of disappeared for a while. And then he resurfaced just earlier this month. And unfortunately, we had two new guys who took up all of our time. I didn't have much of a chance to get to Dan at the end. We just had about 5 minutes. But I'm curious, Dan, why did you go see Denby?
Well, we had heard of the BAT protocol, and I haven't had recurrence yet, so I'm not a candidate for that kind of a therapy. But we felt like it was valuable to reach out to him and kind of get our foot in the door with somebody else who might have a different take on things should I need it down the line. And it's just
I
been
got one other question, Dan. Dan, how was your cancer picked up?
PSA rise. It had been like in the mid 3s for years, stable. And for some reason, I decided to get a second reading in 2019, and it was up to like the high 4s all of a sudden. So then we got the biopsy and discovered the cancer.
Ken Anderson, do you want to do a quick pitch here for Daniel and let him know we run a group for guys under 60 because there's some particular things that guys under 60 dealing with this disease deal with that everybody else doesn't have to worry about sometimes. But Ken, do you want to talk about that for a minute?
I can, Peter, for sure. I finally made it home, so I'm not sitting in my car listening to the phone in my ear. I didn't catch, what was your age?
59.
Yeah, tough. It is a tough thing to go through. We happen to have a call coming up on Thursday that you're more than welcome to participate in, but the information that you're getting is, absolutely true. You want a gen-onc, a geomedical oncologist, to kind of be the quarterback. And you can get treatment anywhere in the world or anywhere in the US. You don't have to go see the guy every time you want care. He's just the guy that kind of guides you, gives you direction whenever you need help finding kind of which path he thinks might be the best route. Are you still working or have you retired or?
I'm still working, but I work from home.
Yeah, well, good for you. Not everyone has that luxury from working at home. Today, it's probably more prevalent than in the past, but by all means, come on the call on Thursday and we can chat more. It's not quite as big a group. There's usually about 10 to 12 guys in the group. So Thursday night.
Is the information on that on the AnCan website?
It is. It's under 60 Thursday nights. I think it's 7 p.m. on the East Coast.
Okay.
So yeah, same room.
Because guys under 60, oftentimes are dealing with young families and oftentimes more concerned about sexual function and this and that. There's a lot more that you can unwrap with a group of guys under 60 that's peculiar to prostate cancer.
And I must admit, I've done most everything. Got a couple more things on the list. So, yeah, come on the call.
So, Daniel, I see that you are on, you've signed up on our mailing list, so you should get a reminder for the under 60 call. It'll probably get sent out tomorrow or
tomorrow.
Yeah, it will get sent out tomorrow. So just keep an eye open for it. It'll be like the reminder you got for this call.
Sounds good.
Okay, well, thank you for joining us, and keep in touch with us for sure, and stay in touch with Len because he knows the docs in New York and everything very well. Even though he might be in Florida right now, he'll be up in Connecticut before too long. Okay.
I have, Peter, I have a question for Daniel, if you don't mind, just to take a second. Daniel, since you've gone so clean, vegan, no sugar, no salt, how has it been being on ADT for you? Have you experienced a lot of the things that we all
No,
experience as in brain fog and so forth?
I had a couple of hot flashes early on, but really nothing since then. You know, it's definitely muscle loss. You know, I can work out as much as I want now, and I have energy to do that. But there's the occasional day where I have fatigue and maybe a little nausea, but that's maybe like once a month. And the biggest thing is just the loss of libido. You know, I just don't think about sex at all. So
Yep.
hoping with ADT winding down and my natural testosterone coming back, that'll change. Even though I know it may take a while.
You want to keep an eye on it.
Let's just give a quick plug then. Alexa, are you there? Turn on your mic if you're still with us. No, she may have stepped away. I was going to ask Alexa to do a promo for the webinar that we are doing on the 31st of January, ahead of Valentine's Day, 2 weeks ahead of Valentine's Day. We're going to do it with a urologist called Dr. Rachel Rubin, and she specializes in sexual dysfunction and incontinence, and she's pretty amazing. We've seen her in action. She did an incontinence webinar for our multiple sclerosis group, and she was just terrific. And we've heard from guys who live in the Delaware, Maryland, Virginia area that when she's shown up at us two groups, she's been really, really good, and we can see why. And this is going to be a mixed group of people, not just prostate cancer people. There'll be some people with MS, there'll be some people with spinal injuries, there'll be people with lupus, there'll be some younger people. So I think it'll be a really good session. We should have the flyer ready in the next couple of days. Watch out for it. We'll be pushing it out, and sign up as soon as we have the registration link. I don't have it. It's the 31st of January, Monday the 31st. It'll be at 8 o'clock Eastern. And if I see Alexa back on here, I'll get her to put the link in the chat window. Oh, there you are. Are you there, Miss Alexa?
I'm there, just the webcam limit was reached. I'll put the link in the chat.
Okay, would you like to say anything else about Rachel?
Oh, Rachel's amazing. Rachel makes everything seem so easy to talk about, which can be a tough subject. And she talks about how sexual function is part of quality of life, and it's an important one we want to talk about here at AnCan too. So I'm really excited for that webinar.
Thanks. And we'll put the link so you can sign up right now. We'll get that link in. You'll be the first people to see the link, so the first people to sign up. So there you go.
Very good. So a couple more quick questions before we move on, Daniel. What is your current PSA right now?
Undetectable.
And how often do you do blood tests? Check your
Monthly.
PSA. Monthly? Good. Okay. Those are the right answers. Okay. Good for you.
Before we go on, Peter, there's a new caller. Can you identify yourself? I know Bill's on the phone, but there's somebody else.
There's two new callers.
Right. Well, one is Bill.
I think John McPhee.
Well,
yeah, John McPhee from Ontario.
Okay.
Yeah, but you're not on.
Thanks, John.
But there is a caller. If you're on the phone, could you identify yourself, please?
It's John McPhee from
Oh,
Ontario.
John? Because he's not a phone. He doesn't have a phone symbol.
Right.
Oh, there.
I think he's on both.
Okay.
Yeah, this is Eric. I joined a little late, but
Oh, hi, Eric.
hey, how you doing, guys?
Doing well.
Okay, Carl, you're up.
Can I jump in just before we do and do a quick pitch for a study? We work with a number of research companies. Probably the best of all is a group called Savvy Cooperative. And what we like about Savvy is that they are patients running this this market research group. And we've worked with them for quite some time. In fact, one of the people who now works for them is one of our moderators, not for prostate cancer. And they called me yesterday and they said, or they wrote to me yesterday, and they're looking for just 4 people who are metastatic castrate resistant and who have failed at least one second-line anti-androgen, which fits most everybody today who's castrate resistant, because there are very few people who get castrate resistant who haven't already done a second-line anti-androgen. In the old days, that wasn't true, by the way. In the days before abiraterone and enzalutamide, that wasn't the case. But today, to be castrate resistant, you pretty much have to have failed one of those. So
Rick, they require you have failed Abby or enzalutamide. I tried to apply for it, and Lupron's not good enough. That you have to have failed.
Well, that's what I just said, Jeff.
Another question.
I just said you have to have failed a second-line anti-androgen. Now, it's not exactly as you say, because we've resolved it. It's not only enzalutamide or abiraterone. You could have failed darolutamide, and you can have failed apalutamide, because we've gone back to the company and we've resolved it. So any second-line anti-androgen, if you failed it, then you are eligible for this study. I'm going to stick it in there. It's a 60-minute study. Hold on, Herb. Hold on. It's a 60-minute study.
Yeah.
It pays $110, and we get $100 for everybody that they see. So I'm going to put it in, and the floor is open for anybody who wants to discuss it.
Rick, I got the same email, but it wasn't clear to me the timing of the failure. Did you have to fail in second line while you were castration resistant or before?
I think that you have to have, well, if you failed it, you're castrate resistant.
No,
so
but
as soon as you
sometimes
fail it, you're castrate resistant. As I said to you guys, it's kind of tautologous. You know,
That's
if
true.
you failed it, you're castrate resistant.
But the wording wasn't, I mean, sometimes you give these second line drugs for even when someone's castration resistant.
Right. It's
Because
not clear.
resistant.
It's not clear. I didn't get into it with them. I mean, to me, if you're castrate resistant, then you've already failed one of these drugs. You may try another one and it might work, but you were castrate resistant when you failed it. So my recommendation is, if you think you qualify, apply. They're only looking for 3 or 4 people. You know, it doesn't take long to apply, and it does say quite clearly here that that the applicant, the sponsor, will want to speak to and qualify the applicant. So it's not a guarantee that you're in, but if you failed one of those 4 drugs, then I would recommend that you apply.
Okay, very good. Okay,
I'm just going to put the link. I'm not going to put the whole discussion. It's on this link. I'm just going to put Savvy Co-op and the link, and then you guys can decide if you want to apply. And like I say, they say they're only looking for 3 or 4 people, so we should be able to fill this one pretty quickly.
Okay. Thank you, Rick. Okay, Carl Forman, did you get your mic fixed?
Yes, I had to log off and log on 3 times for whatever reason. So this is relatively quick. I came across a program called ReVital, and it's for cancer rehab. And I actually signed myself up and started having some appointments as of last week. And the link is revitalcancerrehab.com. And it says it's for those affected by cancer and its treatments. Maintaining or regaining strength and function is a critical part of recovery. So it's a nationwide program. I was able to get it approved through my insurance, and I have Aetna, and I was approved for 24 sessions. And I've just had 3 sessions so far. And I've been very impressed. The physical therapist has gone through very specific training for this. And she actually had told me she was on a Zoom call like this, and she said that they meet every week, and there's over 200 therapists located throughout the country that are on these regular Zoom calls every week. So so far I'm finding it really good.
Can you put it in the chat box?
Sure.
The website?
Okay.
That'd be great.
All right. That was what I wanted to talk about.
Okay, you doing okay other than that?
Well, I met with my oncologist at Rutgers today. I had my latest quarterly shots of Eligard and Exgeva, and in 2 weeks I'm going back to Weill Cornell for scans and my next Keytruda infusion. So to be continued.
Very good. Okay, well, thank you. Carlos, welcome back. We haven't seen her.
Whoa, Peter, okay. Peter. Let's just check if anybody would like to talk to Carl or talk about ReVital or find out about his experience. Anyone got anything they'd like to know about ReVital before we move on, or anything about Carl's experience right now?
Yeah, Carl, this is Len. It sounded like you said it was physical therapy. Have you actually gone for an appointment yet?
Yes, I've had 3 sessions, and it's actually, they consider it cancer rehab. So it's for people who are currently in treatment and are dealing with side effects, with fatigue, with lack of muscle mass, etc. And it's a really comprehensive program. I really like it. I have it. It's an hour appointment. I have twice a week.
And you went there physically, or is it telehealth?
No, physically, because they actually have equipment that they use with you.
Yeah, sounds great.
Very good.
So does this mean they're across the country, and
yes.
Are they working through? They're working through independent physical therapists. Is that what they're doing?
Yes, pretty much, and they have to have certain qualifications and educational requirements that allow them to perform this type of physical therapy.
Do you feel that your lady that you're seeing is knowledgeable about the impact of hormone therapy, long-term hormone therapy in men?
Yeah, very much so. My first appointment, she had asked for my scans, my blood work, doctor's notes, and she reviewed all of those things, and then we discussed them in the second meeting, and she was very knowledgeable.
Fantastic. And what about diet? What are they telling you about diet?
That has not been discussed.
Okay. Anything other than just the physical aspect, physical rehabilitation, or is this really focused on physical rehabilitation?
Yes, more physical, dealing with fatigue issues, muscle mass loss, balance issues.
Great. Okay. Got it.
So Carl, let me check, let me reiterate. So this was covered by your insurance?
Yes, as physical therapy, yeah.
I just posted her in the chat box. I went to the website. It's only offered in a handful of states. Fortunately, not Florida. However, it is Maryland, so you're good.
Right. The DMV is all there.
Okay. Well, a great spot on your part, Carl. And how did you hear about it, by the way?
I was just going for regular physical therapy at the Kessler Institute, which is relatively well known here on the East Coast. Their claim to fame, so to speak, Christopher Reeves, when he fell off his horse, he was being treated by the Kessler Institute, very well known, a rehab institute. And I was going for general physical therapy, and I saw a brochure right there on the counter, and I immediately said, boy, I've got to do this. So
Great. How long did it take for your insurance to approve it?
a few days, like 2 or 3 days.
Fantastic. Okay. Go for it, guys, and report back to us. And some of you in some of these states, try it and see what you can come up with. I see a few states here where we have folks, Texas and Virginia, Maryland, and Delaware, and Minneapolis.
So
Maine.
I had a question for Carl. So do you get a prescription for PT from your oncologist to go to this place?
Yes.
Okay. Very good.
Okay, thank you. Thanks for fleshing that out a little bit. I think a lot of people are going to be very grateful to you, Carl. And we wish you lots of good luck with Tagawa next week. And, we'll be talking to you next week. See how you do.
It's in about 2 weeks. And actually, I'm on the website right now, and there's a locations tab. And I just put in Fort Lauderdale, Florida. Len was talking about Florida, and they do have Cape Coral, Pensacola, and I think those are 2 locations that they have in Florida. So they have various places throughout the country.
Yeah, I guess they're adding them. Their website isn't even keeping up with the new additions. Anyway, too far for me.
Well, when you come back to Connecticut, they have a number of locations.
Oh, okay. I'll be back in March.
There you go.
Very good,
Great.
Carl. Anybody else have questions about it? Okay. Carlos, how are you doing? You just finished up Provenge, correct? Can't hear you. Says your mic is on your computer. You're also on the phone.
Actually, his mic looks like it's off.
Right.
Oh, maybe it's off. Carlos?
I think he's,
Carlos?
yeah. Carlos, I think, was caller 04, and he's calling back in again, is what I'm guessing. So why don't we come back to Carlos, and Carlos, will come back to you momentarily because you're not connected yet, and we'll get back to you.
Okay. Mike Phillips.
Yes. I met my radiation oncologist that we're going to use for my radiation treatments. And previewing it. Go ahead.
Yeah, Mike was told to on the 31st. on the 31st, he's going to have an appointment to place tracers
Yeah, or,
and something else
yeah,
with your perineum.
and the gel.
Yeah, the gel that they do for the rectum.
Spacer.
Spacer, that's
Yeah,
right,
that's
spacer.
And so that's just our next step, and we're waiting for that to happen at the end of the month.
How did you like your the radiation oncologist, Mike?
Well, he seemed like a nice guy. He was young, impressed my partner.
Oh, he's handsome.
But he had the answers, and and it seemed to line up with everything else that we've been told up till now.
Okay. And when you say they put in the tracers, are these gold fiduciaries that they put in, or are these the transponders? Do you know what system you're going to use to guide?
He just described it as a marker, and
It's going to be there forever.
yeah, it's permanently implanted. And
Right.
I think he told us what the method of tracking it is, but I don't recall.
Did he say anything about SBRT?
Yeah.
Did that come up?
SBRT, yeah.
Is that what we're having?
Yes.
Or CyberKnife?
No.
He did not say so.
No. Okay.
No. So we're just going to do 8 weeks, 9 weeks, 5 days a week.
Okay, so that's not going to be SBRT. That's going to be what's called IMRT.
Yeah, that's it.
That's correct.
There are so many acronyms.
So many RTs.
Yeah.
I know. So what I'm going to do for you momentarily is I'm going to put a link to a pamphlet that is published by UCSF, which explains radiation for prostate cancer. And it's easy to understand, and I recommend you read it. I'll stick the link in there when I finish talking, and that'll explain to you what IMRT is. I actually did that therapy myself, along with brachytherapy. The question that I have is, you say you're doing 5 weeks, which is around 25 sessions, right?
Actually, it's 9 weeks.
9 weeks. Okay, that makes more sense. Okay, got it. All right. All right. And how far is this from the house?
About 20 minutes.
Okay, well, that's not so bad. Did he talk to you about whether you need a full bladder or not a full bladder, or anything about like that?
Yeah, he said I might have a full bladder and an empty colon.
Full bladder and an empty colon. Would anybody on this call like to give Mike any tips or advice from having been through this full bladder and empty colon routine before? Because there are some helpful tips that some guys may have for you.
Yeah, Mike, you want to bring a water bottle with you, or if they have water there, whatever, and start drinking when you get there. That's what I found. If you start drinking too far ahead, you're never going to make it. It depends on how fast they get you into the room after you change it. But I used to go and change my clothes, and I'd start drinking then, and that would give me the full bladder, because you're not going to be on the table too long, but it can get pretty squirrely and uncomfortable if you start drinking too early. Be careful of that.
Okay.
Yeah, I used to, I had to do the same type of thing. I had 40 treatments, and I found that as soon as I arrived at the facility, the first thing I did would be empty my bladder. It seems counterintuitive, but then start loading up on water. This way you didn't have if you started drinking when you got there and you're still carrying what you may have had, you know, for me, it was a 40-minute drive to get to the facility. So it was a no-brainer for me. Go in, empty the bladder. I'm in the waiting room, you know, you sign in and, you know, you drink, you need about 20 ounces of water. You don't need all that much. And it is a race to the finish line, though. By the time you get in there, get on the table, get set up, by the time they're done, it's like, get me to the restroom. That's the way it's going to be.
Okay, great.
If it's if it was anything like the place I went, Peter's right. You're not on the table long. I was literally on the table mostly 5 minutes, I guess. But my drive was about 30 minutes, and my advice: if you're going to start drinking before you drive, know where some pit stops are on the way, because you might have to stop. But no, seriously, yeah, make sure it's. I actually went in a few times, and you know, they after the session, there's like, well, your bladder wasn't as full as we would have liked, and that can lead to other problems. So try to stick to their regimen. So. And yeah, you'll be on the table, even though it's only 5 minutes, you'll have to go. My place that had a bathroom right outside the door of the radiation room. So that was every man's first stop when they got out of the radiation room. So
yeah, one other thing I could think of, depending on where you have to go, what did you say, 20 minutes away from your house?
Yeah, it's about 20 minutes.
Oh, that's not bad. I had to go to work from there at the time. I was still working. So I would go early in the morning, 8 o'clock, get my treatment and go. I used to hang back because this treatment has a way of stimulating, I think, your bladder. I know I urinated a lot when I was going through the treatment. I didn't come away with any bladder damage of any kind. But when I was going through it, it seems to irritate your bladder. So I had about a 45-minute drive to my office from the facility where I was getting my treatment. I would actually sit in the facility about 15, 20 minutes before I left and just try to empty my bladder as much as I could before I get into the car to go to my office. And then it was always a race to the bathroom as soon as I got in as well. All that calms down when the treatment's over, though.
That was my experience as well. I used to spend 2 to 3 hours up in the urology department of the hospital, and until my bladder calmed down, and then I'd hit the streets and feel comfortable going out. But it took a while. It does get stimulated somehow, but that's not everybody. The other thing is you got to watch your diet too. You want to change your diet. Just eat things like white rice or pretty bland food, and stay away from spicy Mexican, Indian food, that kind of stuff for the next 3 months, because you can get a pretty bad upset stomach during this process.
Yeah, I would not drink any coffee when you're going through this treatment.
Yeah, I was gonna
stay away from coffee.
I was gonna mention about your diet. They did give me a sheet that what kind of foods to kind of stay away from, because some foods can still make you like gassy, like onions and stuff like that. To try to refrain from those while you're going through that treatment.
I see.
Definitely.
I'll try to find it. See if I have a soft copy. If I do, I'll put it in the chat.
Yeah, on our website, we've got some UCSF dietary things from the dietitian, and she's excellent. And she might have, I know she provided something specifically for going through radiation, the diet for when I was there. I don't know whether that's on her general stuff on her website or not.
Okay, I can try to find that.
Yeah,
Most of the time, too difficult, except the coffee part.
It's a low fiber diet, is what they called it for me.
It's almost like the opposite. It's almost like the opposite of what your diet's going to be after the radiation.
Yeah.
I've had problems with, actually I had 33 treatments with a full bladder and then 25 with an empty bladder, 2 different rounds of this last couple of years. But the difficulty I've had is actually with my GI system. It's kind of cooked, I feel like. I've had diarrhea about once a week ever since. It's been more than a year now. And that's, so the bladder's okay, but the rest of my colon, my large intestine, I think, has been unhappy about this treatment. So there is the part during the treatment that was fine. It was afterwards that I've had problems with.
Oh,
Have you tried probiotics?
Yeah, every day. We just tried it. All gone. I'm sorry.
Yeah.
Still a problem with me.
Yeah,
So
I mean, radiation's doing its thing. I mean, it's invisible, you know, I mean, but it's doing what it's supposed to do, but it can kill some other good aspects of ourselves as well.
terrific. Well, I appreciate the advice, and I'm gonna do everything I can.
So I know this particular topic was for Mike Phillips, but John, your comment on your issues after radiation treatment. I also had a lot of issues, which we don't need to go into, but I've recently started something that another friend of mine pointed out to me is there was a small study that showed that grapes apparently help your intestinal tract quite a bit. It was a small study, and I can find it if you want me to, but he read it, he sent it to me, I read it, and basically it's eat between 20 and 40 grapes a day. Red, green, or the dark red ones that look almost black, and supposedly they have a lot of good stuff in them. And someone just said it and went right out of my head. Probiotics, yeah. So
probiotics. Well, I appreciate you saying that.
They're not probiotics per se in the grapes. It's what they call prebiotics because it's before it gets into your intestinal tract and helps the probiotics that are in there already. So the good bacteria.
Reduced the consumption of bran. I don't eat any nuts, anything like that, and have increased applesauce. Actually, is a good thing.
Plus, apples are good for you.
Yeah.
I had radiation in 2014. I did not have to pee right after. I didn't do it till way after I got home. I had never had urinary problems as a result. I can go all night without a problem. I've had no bowel problems. I've had no other problems from the radiation, and it was in 2014, 8 years ago. So you may have problems, you may not. And I just wanted to give the counterpoint of view because I went in with I guess a half full bladder every time is what they wanted, but it sure worked. For 3 years.
That's an excellent point, Jeff, because we've had a lot of discussions like this in the past, and we've had a lot of men say they didn't have any issues with radiation, and we've had men like myself and some of the others on here that had issues with their radiation. So don't worry about it until it happens to you. That's what I always say, Mike. It is the standard of treatment, and it's going to help you. Don't worry about all the other stuff unless it happens. So follow your doctor's advice.
I have a couple of questions. My first is to Bill Franklin, and this grapes business, Bill, did you find out if wine counts instead?
Yeah, that was kind of a question I had for my friend. He said that was not mentioned at all. In actuality, in the study, they didn't. The participants didn't actually eat grapes. They specially designed a grape powder, a powder derived from grapes, just for the study, and fed it to the participants. But the takeaway from the study was that if you just ate grapes, it might do something similar. But
okay, well, somebody can try it with wine. Somebody can see if wine works. The second thing is,
you guys, I need to chime in. The only problem is for any of you guys with advanced prostate cancer, you got to really watch your sugar intake. So I wouldn't be eating a bunch of grapes.
Well, yeah, that's also something.
I mean, if your cancer's under control, it's another issue. But I mean, if you're trying to control your cancer, adding a bunch of sugar with grapes is probably not a good idea.
Okay.
The second thing I wanted to say is that I put the radiation pamphlet link in the chat window, so you can click on it and it'll open and you'll be able to download it and read it later. Right. And the third thing I wanted to say is this actually happens to be one area where I do have a lot of peer experience. In fact, I've got an appointment with the GI doc on Thursday, But in my case, I had irritable bowel when I went into the radiation. Would it have made a difference as to what I chose? Probably not. I probably would have said, I'll take my chances. Has my bowel been damaged by the radiation? Yes, absolutely. Is it better than the alternative? It sure is better than the alternative. And you live with it. You know, what can I say? I curse and I get upset and it's not great. And I've been playing around with my medications recently, not so successfully, which is why I'm going to go see the GI doc to see if I can reset my medications. But some people are like Jeff, and that's just fantastic. Other people can have significant issues like John. I suppose in a way I would have to say I have fairly significant issues, but you live with them, you know. I'm happy, and you make accommodations.
All right.
So hey, Rick, I wanted to squeeze in one practical tip to Mike, because I know it's going to be soon before you start these treatments. And in my experience, I think this is true for most guys, they're going to want you to have a reasonably full bladder. And the one thing in my experience is it's better to go in there with too much in your bladder than not enough. Because if you don't have enough, then guess what? Your session gets postponed while they hand you water, and then you have to drink it, and then you have to wait for it to filter down to your bladder, and that takes a while. And there's nothing more fun than sitting around in the waiting room while you watch other guys breathe in and out. So that's my advice to you: is better to have drunk more than you needed than to go in there light.
Great. All right. I really appreciate all the suggestions and.
Okay. Yeah, I've got a buddy here in Hawaii who actually practiced fasting. He practiced fasting quite a bit when he was on radiation, and it worked for him. There's lots of different techniques, but bottom line is you'll do okay. This is many of us have been okay.
Try and get nothing to do with your bladder or your bowels, but try and get a little exercise in every day. A walk in after your radiation, even if it's only 15 or 20 minutes. One of the reasons for that is because this radiation is going to be aimed around your hips and your pelvis. And there's a lot of bone marrow in there, and you can get pretty fatigued, not at the beginning, but when you've been doing it for a little while, about the second or the third week, you can start to feel tired. And we know that if you get some exercise in every day, you're going to feel way better than if you don't.
Yeah, because
that's a good point.
I would second that. Definitely go for a walk after every session. You know, just go for a walk. Take 15, 20 minutes and go out and get some exercise. Rick's absolutely right, because it compounds after time, and you will like to slow, but it's not a good idea.
So I got lucky in that aspect. So I went walking for 30 minutes every day, and you know I exercised in the house and stuff like that. So I never had to really deal with fatigue. Maybe I was just lucky in that aspect, but I did do that every day.
You weren't lucky, Eric. You did exactly the right thing. That was because you did the right thing, man. Good on you.
Yeah. Well, thank you.
Okay, we're gonna move on a little bit. We got quite a few guys to cover still. Carlos, are you with us now?
I'm hoping I'm with you. Do you have audio for me?
Yes, we hear you.
Great. As you alluded earlier, I had recently gone through Provenge the month of November, and took a little bit out of me, but by the middle of December, I was well enough that my wife and I took a few weeks and went to go visit Antarctica. So now we're back and get back in the swing, go see doctors, figure out what the next step is. And so I'm turning to the group to get some indication as to what they have experienced is the timeline for monitoring the effects of the Provenge. Is it a matter of waiting a week, a month, 3 months before I get studied? And second part of the question, what studies are seeming to be the best options at this point, since my PSA no longer will be of particular value?
I guess my first question is, why will your PSA not be of particular value?
You know, from reading about Provenge many years ago now, that I understand that the PSA is not going to be a great number to follow after having received Provenge. I don't know for how long. I don't know what the history of that it has been, you know, over the past 3 years or so, when I had originally asked for considering that treatment.
So I don't
Carlos,
think it's.
I've been reading a lot about it.
Look, I don't think it's fair to say that the PSA is not of particular value. It's a very, very important value. What it is not going to do is tell you how effective the Provenge is. So it doesn't mean that the PSA. It doesn't mean that PSA is not still an important marker for whatever you're doing. The issue with PSA and Provenge is that PSA is not a good marker to indicate the impact of the Provenge. That's sort of a different way to say it.
Okay,
Herb,
which then leaves imaging.
Herb, you've done a lot of research on this Provenge. What's
Well,
your
I'm
take
about
on
to get it. I'm about to start it. And yes, I echo what Rick said. It's not an indicator of Provenge efficacy, but it's certainly an indicator of what's going on in terms of the volume and of the disease burden. So it won't lower your PSA.
That is what I was trying to get at, exactly.
But we just have to sort of make the assumption that it's working for us, because there's no way, there's no test that says that it is.
Short of imaging.
Well, maybe imaging. I'm not even sure about imaging.
So I think, let me give you a framework that might be helpful in terms of thinking about Provenge. It's kind of like a wagon train that circles around the bonfire, and think of the bonfire as the tumor, right? And it doesn't kill the tumor. What it does is it encapsulates the tumor and it stops it from spreading, but it can still spread within that balloon that it's created where the dendritic cells ring the tumor. So what happens is you're still making the PSA because the tumor can still be growing, but it can't grow outside. And some of you guys have heard me say this before. They actually saw this back in 2009 when Larry was before it had gone to FDA, and Larry Fong was doing clinical trials at UCSF, and they got some people in to see what the impact of doing Provenge might be if you had low-grade disease before you had a prostatectomy. And so people did the Provenge, and then they had the prostatectomy, and then they took the prostate and they sliced it up, and they could physically see how the dendritic cells were interfacing with the tumor in the prostate. And what they could see is that the dendritic cells were surrounding the tumor. And I think that's one of the reasons why we don't necessarily see it reducing the PSA. What we see is it restricting the tumors and the growth of the tumors. And that, and I want to go back to Herb. Herb, maybe you can summarize what the fellow from Dendreon told us in that presentation for us two group leaders.
I mean, he didn't talk about mechanism very much, if I remember, Rick.
No, the effect of
Well,
Provenge.
the effect was significant in terms of, so they did show a significant effect on survival depending upon PSA level when you got it. And the lower, more or less, the lower your PSA level when you got it, if you got early or low tumor burden, it extended life by a year. Right, so that's pretty significant, which is why I'm going for it.
And that's just the medium. Let's hope Carlos, you and Herb and anybody else goes way beyond the year results. So that
No, it extended life a year beyond no Provenge. So what they said, for example, with low PSA and given Provenge, the median survival was approximately 4 years.
Okay, but that's the medium. Let's hope you guys are on the far side of the medium.
Peter, we are all hoping about that, but a median's a median.
Right.
So what everyone's saying, Carlos, is watch your PSA. Do scans, every 6 months or thereabouts, but watch your PSA as well.
Right, but I think it means we still need to move on to some other therapy after Provenge. And I think agree. Carlos and I are on the same wavelength here. That we're going to have Provenge, but we've got to do something other than just circle the wagons.
Right.
Correct. Yes, now, I'm due to see Dr. Bryce on the 17th, and his last words 2.5 months ago were, "Yes, Provenge is something we will do along the way before we move to the next step." In other words, yeah, if you can get Provenge, great, but otherwise, I'm ready to move you on to the next step. I think he said I typically would go to chemo at this point, but let's wait until the turn of the new year. There may be other options available, and I think he was alluding to lutetium type treatments. So I can fill you in as soon as I hear what that word is. I also will be consulting with Dr. Scholes in California to see what his take is on it, and then we'll see what my options are and how we're going to monitor it.
Yeah, recently we've talked a lot about the lutetium, and it's not available yet. Hopefully it'll open up at some point, but at this point that door is closed right now.
Quick question: does anybody know if Provenge is considered standard of care for castration-sensitive
no
status?
It is not. It's not.
No. Okay. Thank you.
Not yet.
You have to have two successive increases. Is that right, Herb?
Two successive increases, or even a scan showing castration resistance.
You guys, I know that's true, but I can tell you I got it when I was castrate sensitive, and my insurance paid for it. So I would ask the question to your doctor, because the whole thing about being earlier is better is true. So I'd ask the question and see if your insurance company would cover it. I know.
Yeah, so my insurance is Medicare, so that'd be the one I'd be wondering about if anybody's crossed that bridge.
Medicare does cover it.
That's
for castration sensitive.
Yeah. That's the advantage of
that's
having.
A good question. I can't answer that part.
That's the advantage of having a GU med-onc that's progressive and goes to bat for you, because sometimes they can open doors that maybe normally wouldn't be open.
Yeah, it's probably
great.
true.
Thank
Peter.
you.
So Carlos,
Thank you, guys.
did you have the Polarify PSMA scan yet to see how much is PSMA avid?
I had gallium.
The actionable? Yep.
Yeah, G11.
I know you're in Phoenix. They're doing Polarified, MD Anderson, and Gilbert.
Okay.
And it does kind of tell you how many of your cells express PSMA. So might be
Okay.
worthy doing before they approve lutetium.
Okay.
But Ken, he had a gallium 68. Carlos had a gallium 68 R11, so that's going to give an indication of how PSMA avid he is.
Okay.
Exactly.
That's a PSMA scan. It's not a Pylarify scan. That's with a different agent and a slightly different. But the gallium 68 is a PSMA scan.
That is correct. And that was part of my second part of my question is anybody familiar with any literature suggesting that one type of scan it would be better at this point for monitoring than the other going forward after Provenge?
The answer is yes. I mean, Alan Liddell wrote a great piece a couple of years ago, now maybe even 3 years ago, where he compared all the scans and the Pylarify, the 17 DCF PYL is considered to be the best of all. It's a little better than what you had. Not significantly, it is a little better, and it's better than Axumin. But if you were going to scan again, that might be the one to do, but then it's not going to be comparable with what you've done before. So you might see new stuff on this and you might think that's a new lesion, but it really isn't a new lesion. It just wasn't spotted before. So you have to measure, you have to consider that comparability issue as well.
Yeah,
Carlos,
and Mayo was due to get POI going this fall, but apparently that has been unfortunately slowed way down. So we'll see where we are with that as well at my meeting.
Carlos, you said you had side effects from Provenge. What were they?
I try to forget these things, but as I try to recall, my biggest issues were during treatment, and I believe I may have spoken to some individuals or even the group in the past regarding that. But primarily, it's a process that takes 3 to 4 hours, and they want to collect a minimum amount of cells from you, and they can run the machine at 2 different speeds. And the issue is that as it's doing so, they're adding a chemical called citrate to keep the blood from clotting in the machine. And when that comes back to your body, the citrate binds to your calcium. Your free calcium drops, and then you start getting side effects, which primarily are numbness and tingling. And you'll notice that around your lips, went to my nose, went to my face. By the time it got to my fingers, I'm saying, hey guys, we gotta, slow this thing down. They actually stopped it the first time for about 20 minutes. The chemical bond breaks down in about that length of time, so they were able to resume it and finish it. And so the next round, I said, hey, we're just going to go slower. And it's okay if it takes 4 hours. It's just you got to sit in one still position for 4 hours, and that becomes uncomfortable. But you're in a big back easy chair. You're essentially laying down, and so you're relatively comfortable. Your only issue there is bathroom issues, which I would recommend you just put on a pull-ups, and if you got to pee, you got to pee, and that's the way it goes. And that's an easy way to manage that particular problem.
So Carlos, can you read while you're doing it, or do you just have to lie there?
Well, your arms are like this, straight out, because they've got needles that are bare needles in the veins, and if you bend them, the probability of you cutting those veins and losing your access is pretty high. So short answer is you can read with your eyes, but you can't really handle anything. You really can't be moving your arms around. So they can put a TV on, I suppose, or you can just put some earphones on and listen to a book on tape or something to take up your time.
The people that I know who have always watched a movie, the people that I know that have done it have always found the best thing to do is to take a movie in or a webinar or something like that.
Yeah, Herb, do a podcast, a webinar podcast, some clinical trial that you're interested in. Just load it on your computer or your phone and listen to it. Because you cannot
Or
move
you
your
could,
arm.
or you could go to sleep. However, they
Or-
kind of frown on that because sometimes you start getting confusion, and that's sort of your first tip off. Things get a little bit foggy. It's like, all right, let's see if this is going to ease up or not.
This is great information for anybody going through it. Yeah, I've always heard
Sure
that.
is.
Pretty uncomfortable.
It's just holding still. That's the uncomfortable part. And if they pad and get pillows under each arm, and essentially you're swaddled in a position that you can lay in, it's tolerable. It's that last hour that gets tough.
But you can walk away from it. You're not disabled. You don't feel any disability to go home.
Correct. Now, my last session, I ended up with the same issues coming up. Didn't have them quite as bad as my second round because I basically said, look, we're going to go to a slower rate, and we'll collect what we collect in 4 hours, and that's that. And so I had the numbness and tingling, like I said, in 20 minutes after they're done. By the time they're all done boxing everything up and getting it all ready to package and go, everything, you re-equilibrate. That free potassium, that potassium is freed,
Okay.
and you feel back to normal again.
Okay.
I'm sorry, calcium. I misspoke.
Calcium. Yes.
They don't, Herb, you can get in your car and drive home.
Yeah, that's what I had to worry about.
I used to take a walk and get a green smoothie at Whole Foods, but you can get in your car and ride home. It's no big deal.
I think I heard somebody say that it was a good idea to bring Tums with you or some such calcium supplement.
Yeah. They actually have you preload for the first, for 3 days prior, either with yogurt or taking Tums, a couple of grams a day. In fact, when you sit down, they'll give you a gram of Tums. And then halfway through, if you're complaining of tingling, they'll say, here, take some more Tums. Yeah, it helps, but time is the cure on that.
Okay. Well, thanks very much, Carlos. I've been thinking about
All right. Well, I'll let you guys know what they recommend for imaging and follow up of that. See you next week.
Okay. Dennis McGuire, you're up.
Hey, everyone. Quick update on lutetium and a PSA update. So I had a lutetium treatment in mid-December, and I had a PSA update at the 3-week mark, and my PSA decreased by about 50%. And my next treatment is next week.
That's great. Congrats.
That's great.
Thank you.
Can we put some numbers to that, please?
Yeah, when I started the day of treatment, my PSA was at 300, and at the 3-week mark, it was at 150.
Wow, so pleased to hear that.
Yeah,
How do you deal with 300, Dennis? My PSA just went up to 50 today.
Well, that is the hazard of being off treatment for 7 months.
Wow.
Yeah.
Glad it's working for you, because I hope I'm following you.
I want to say one little thing about lutetium. We'll come back to you, Dennis, because today some of us got a report from Al Latimer, who couldn't be with us tonight, showing us how he had responded, and he is not a typical lutetium patient in that he hadn't been through chemo, but they took him, and he only had nodal disease, but he was germline BRCA, and he'd failed Olaparib. And one of the interesting things was that his PSA climbed for the first 3 treatments, and then it declined after that. And that was important to me today because I heard from Jerry Deans, who is really wrestling the demons right now because he's having cognitive issues as a result of the brain mets. And even though those mets were treated, he's still having an impact. And he got his first lutetium treatment, and he was over 1,000. He dropped down to 911, and today he measured again, and he was at about 1,078. So I sent him the graph that Latimer sent, and I had said to him, sometimes people go up before they come down. And I just want everybody to know, because a lot of people on here will be doing lutetium, that you don't always see an immediate decline. It can take 2 or 3 treatments. And so I just want to put it on your radar. Don't get bent out of shape if you don't see that immediate decline. I mean, look, and Dennis, I mean, I know your history has been complicated because you did 3 and in a different regime, and now you're doing more, but you didn't really see an immediate decline to begin with, did you?
No, I think, no, in both treatments, I got a response after the first treatment. Yeah, but to your point, Rick, I think the ultimate goal here is durability. You know,
right.
It's if and when you stop lutetium, do you have durability? That's the big question.
Right.
Right. Well, we wish you well for sure. This is, you know, unfortunately, you know, for many guys, it's not available now, and I'm afraid that there's going to be a rush to get in on it when it does become available, and some people, you know, it's going to be like Jerry, it's going to be at the end of the rope rather than early on. So it's unfortunate. You know, hopefully this will eventually be available to guys early on in the treatment rather than right at the end.
Yeah, Peter, my chat with Paul was that, you know, anyone that can get a PSMA scan early on has an advantage. Most likely, you know, Medicare is going to be kind of the first one that rolls it out. And since it'll be FDA approved, everyone's kind of fingers crossed mid-February. It could be later. But, you know, we just don't know whether or not there's going to be this little like tag along that states that you have to have so much of your cancer that's PSMA avid. So I know Dennis was lucky he got in, but it sounds like most of his cells are PSMA avid because he gets a real strong response. Larry Fong, you know, his comments were, because I talked to him at UCSF, his comments were, you know, combining it with another drug, you know, may show a stronger like longevity, because it on its own, and it'll kick cancer cells down the road, but it won't hold them there.
Yeah. I mean, there are trials now of lutetium
I know,
and
I'm
Olaparib.
looking at them. I am looking at them, Herb. So
So I think there is.
if you see anything that looks interesting, send it my way, because I'll
Yeah,
travel.
well, I'm looking too, man.
So let me just say a quick thing about lutetium. And this is my own personal take, based on a few conversations I had with the pharmaceutical. But my feeling is that the big problem right now is an inability to deliver the lutetium in the centers that have already been approved for to be able to use it, to infuse it. It isn't related to manufacturing the drug or the ligand. It's related to the ability to get it into the person. And I mentioned this to Advanced Accelerator Applications several months ago, and they did some talking, and sure enough, they pulled the trial because I think my feeling is, and it's just a guess, that they realized that if this thing got approved by the FDA and they couldn't deliver the drug, they were going to look awful silly. And we're going to be a lot of very frustrated people. And I think they said, we've got to get our act together to be able to deliver this drug when it gets approved. And I wouldn't be surprised, I don't know, but I wouldn't be surprised if they reached out to the FDA and said, please don't approve it right now because it cannot be delivered. And so my plan is, originally they told us the middle of February, maybe March, that is when they hope to come back with it. And I will reach out to AAA middle of February, and I'll see what we can find out. I don't want to do it before then because they definitely said it wasn't going to be before the middle of February, but it may be they've got to push it off another couple of months. But I do think they said clearly it was a logistical problem, and I think the logistical problem is the ability to deliver it to patients, which is not wide enough spread right now.
So Rick, can you elaborate on what you mean by a problem with delivery? Like, I don't know if that's the actual physical mechanism, or I just don't know what that means.
Yeah, I mean, my thought is, and I don't know for sure, but we've kind of heard this, there are not enough radionuclide trained medical staff. There has to be special, there has to be nurses or technicians that are trained in using radionuclide. So it would be the same people that might give radium-223 right now. And there aren't enough of those people. So you could have what you need, the lutetium and the ligand in place, but you've got to have the people who are trained to deliver it to the patient. And I'm just guessing, but we heard this about 6 months ago from certain centers that they didn't have enough staff, and that's why they couldn't open up the managed access trial. That was what was holding back the managed access trial. Now, there's another thing too, which is each one of these centers that has been designated has to have a protocol approved. And Herb knows more about this than I do, but the hospital has to approve the protocol. And some of those people were having problems getting the protocol approved. Even though they were designated as a center, they couldn't get the protocol approved in their particular hospitals. But we know that Mount Sinai did, and we know that Chicago did, and we know that UCLA did, but it was not as easy as it first seemed. But this is above my pay grade. Maybe Herb can throw light onto it.
Well, I don't have any more insights than you do, Rick. I mean, the one thing I will say is lutetium has a half-life of about 6.5 days, which is really good. Means if they have to ship it and it takes a day, there'll still be enough activity to use it. So it's not like something where you have to have a cyclotron on site to make this stuff.
Right. So, do we know anybody in Australia or Germany that's gotten a lot of mileage out of this? Like several years, because it's been approved there for years right now.
Right. They must have data.
Yeah, they do. And do we know anybody personally?
Yeah.
Only one person, but they chose to get it before when they were castrate sensitive.
Right.
And they really didn't have good evidence even of metastasis, but they were pretty certain that they had nodal activity, and they flew to Australia and they got it, and they've been good with it since. So this is more evidence that the earlier you get it, the more lasting it can be.
Good. Okay. Well, hopefully it'll get online at some point soon. Jim Ward, you had something else you wanted to talk about, yes?
Yeah, real quick. So I saw an article. Bear with me. Sorry, I'm pulling it up. So it was about the 23andMe. They got this FDA clearance for a prostate cancer risk test, and it centers on a mutation on the HOXB13 gene, and in particular the G84E variant. Well, I'd never heard of this. I'll call it the HOXB113 gene,
right.
Although I went back to the old Ambry genetics report and saw that it was in that, extensive list of genes that they test for, but I've never heard of this stuff.
Okay.
HOXB, it's well known. HOXB is well known.
Yeah, and we've talked about it on here before. And if you have a mutation in HOXB, you are very likely to be susceptible to prostate cancer. I don't know. Is anybody on the call have HOXB right now? No.
I had HOXB 13, Rick.
Oh yeah. Okay. Thanks, Joe. Yeah, that's it. That's it. Now I don't know if it's the variant that they're using, but HOXB 13, yes, and so if you show HOXB 13 and it's germline, then your kids are likely to if they're male, are likely to get. But I think the cat's okay, Jim, in your case.
Yeah.
Well, I figure so, but what caught my eyes, it said around 1 in 70 people of European descent have this variant. And since I'd never heard of it, my mind sort of jumped to the thought of, hey, I wonder if I have that variant. And then, I went to the report, and evidently I don't. And so, anyway, just curious. It's not something I've heard of.
Yeah, I mean, my radar comes up when I hear about, I hope nobody uses 23andMe for medical testing. I mean, I don't think it's ready for prime time with 23andMe, but that's my opinion anyway. Maybe I'm wrong. Maybe I'm off base. Maybe they're changing their game and strategy, but I don't think it's the go-to firm.
That's it. That's all I got.
Quick question for Dennis McGuire. When's the next infusion, Dennis?
Next Thursday.
Oh, okay. All right.
Okay. John Vandenberg, you had something else you wanted to bring up, yes?
Very quickly. So my meeting with my oncologist is in about 2 weeks. And when I met with him last, I proposed that I was intermediate risk, and his fellow agreed with me. Of course, the fellow walked out and spoke to Dr. Armstrong. Dr. Armstrong came in with a ton of bricks and said, "You're not intermediate. You're high to very high risk. You've got to keep with the program here. Keep taking the ADT all the way through for 24 months." And I tell you, I'm sick of it. I just wonder if there's any new studies that would suggest that the Stampede study is not the only study out there, but there may be one that shows that 18 months is enough for now. And I just want to get any opinions about 18 versus 24 months, because that's kind of my critical issue that's coming up in the next couple of weeks. Because, in 2 weeks, I suspect he's going to be ready with a giant shot in the ass again. And I would just as soon not have that, which is the Lupron, and I'm taking 750 milligrams of Abby right now. So any thoughts about that would be appreciated.
We are going to turn this to our expert on this call, on this subject, who just spoke to us, Mr. Jim Ward.
Why did I know that introduction was coming? Yeah, I know that Rick and others would agree that it just seems like you will hear from various oncologists. It's certainly what I got from my GU med onc at MD Anderson, and she is also the radiation oncologist. I was chomping at the bit, as Rick knows, to go on a so-called drug holiday. Right. And both those treaters said, we'd feel a lot better about it if you would wait 24 months. I said, okay, I will stick it out for 24 months. And I started drug holiday in January of 21. And now I just reached my 1-year anniversary and just got my lab test from last Friday, and it came in undetectable. So it's undetectable. That's great. For that year. It blipped up, and Rick will also say, don't worry too much about these numbers. But the next to last lab that I had in December, it went to 0.120, which made it technically detectable, and then this time it went under 0.1. So I know obviously some guys are dealing with much bigger numbers that I'm sure will come my way eventually, but it's 24 months was the consensus on my team, and I think that I've heard Rick say it's better to stick it out for 24 months if you can manage it.
So that's very helpful. At what point when you stop to take the drug holiday do you start feeling the benefits of not taking these drugs? I mean, it must be a tailing up, tailing off kind of process, I assume.
Yeah, I think it varies. It varies a little bit, but I can speak only in my experience. It took me about 3 months to go from testosterone that was less than 3 to a number that had a 200 or 300. It took, I think, about 3 months. And I would say that, yeah, those first 2 or 3 months, I couldn't really feel any difference. If I felt different, it was just psychologically, I felt better because I stopped doing the ADT. Yeah. But I can tell you after, a few months, definitely the issue with fatigue and all of that stuff kind of fell away. And I certainly felt a lot better. So you might be looking at 3 or 4 months before you really start to feel a significant, benefit.
Well,
I would echo that too. I did it. I went on drug holidays 2 or 3 times over the years, and it took 3 months for testosterone to come back to feel a little bit better. Are you checking testosterone with your blood work every month?
About every 3 months.
Every 3 months, you're tracking it.
Not, it's around 20. It's just stable. It stays around 20 the whole time.
It'll probably come back. What was your baseline before you went on the drug? Did you check testosterone then before you started?
I can't recall, but it was, I really don't remember. I don't remember.
Okay.
Yeah.
So I had a question. Does anybody know, maybe Len might know this, about taking a partial drug holiday? And by that, I mean, those of us who are on the dual medications, I'm on Lupron and Abby. Can you take a break from the Abby for a while? I asked this question because I recently had hip surgery, and as part of my post-operation, post-surgery instructions, I had to lay off the Abby for 1 week. I ran that by my oncologist, and he said, okay. And I swear to God, I felt better. Just for that 1 week of not having the Abby, you're still on the Lupron because that's an injection. So is there any study about that kind of thing? Like, take a break from the secondary and then go back to that?
Logically, it doesn't. Logically, what people want is to get their testosterone back, to bring that back. By dropping Abby and keeping Lupron, you don't gain that.
Right.
Right. You're simply giving whatever cells need Abby a chance to grow. But you're not going to feel that you're not going to feel like you're on a holiday.
Oh, Herb, I can say I do feel better not doing Lupron at the same time I'm doing Abby.
Huh.
So Abby on its own keeps my T levels below 2.
Right.
So 24, 25 months ago, we dropped Lupron and I'm on a monotherapy with just Abby. And the fatigue is definitely less. I would for sure talk to your doctor about it first, but monotherapy with the stronger of the two drugs, which is Abby, and Paul Korn's eye was acceptable. Doing Lupron on its own, maybe not. Because on Lupron, my T level ran around 27. On Abby, it runs around 2.
That's interesting, Ken. I think that's really fascinating.
Yeah, Len and myself are on monotherapy darolutamide, and we both have the experience of our testosterone coming up, and neither of us are taking Lupron at this moment. Correct, Len?
Yeah, that's right. Now, Peter, what you could do is drop the Lupron, stay on the Abby, but lower the dose. As I think someone earlier tonight, maybe even 2 people said they were taking 750 milligrams of Zytiga instead. Yeah, there you go, Jim Marshall, instead of 1,000.
But drop the Lupron or stay with it?
Drop the Lupron, stay on the Abby, which is better at suppressing your T level, but lower the dose and see how you feel. You might feel a little better.
Yeah, right now I'm on 1,000 of the Abby, and I'm on the Lupron 3-month injection, and it's pretty intense, you know. It does get to you.
Yeah,
So
and as Ken said, he's been on Zytiga monotherapy without Lupron for quite a long time.
So Ken, but you still
track,
need prednisone.
Yeah, I do 5 milligrams of prednisone.
Yes, me too. Me too.
Oh, yeah.
Keep track
Ken, what's
of
your
your
Abby?
levels.
What's your Abby dosage?
I take 1,000. You know, I talked to Paul briefly about doing a lower dose, and he wasn't too keen on it.
Yeah, this is
I don't
why
know.
you want a good GU medical oncologist, one that you can talk to and reason with, and sometimes argue with. And you know, I know that's my case. I mean, my doc wanted me to go back on Lupron. I said, well, how about we try this for a while without it? And if things go south, I can always go back on it or get a scan or whatever. But we'll just watch the thing and experiment, because nobody's got the ultimate answer on this stuff. We're all a little bit different, and we're going to respond a little bit differently.
Well, I appreciate that. I actually type out a whole page of questions and points to make with my oncologist, and he appreciates that, because I go in and I hand him a copy of it and say, here are my questions. Let's start here. And that really, I think, focuses the discussion where my issues are brought to the table. Instead of him saying, well, you got any questions? It's like, yeah, I got questions. This is a whole set of them here. Works very well for me.
Yes.
It'll be a while before we might have some.
We strongly recommend that that you walk in with questions. I think it's, you know, you type your questions, you give them a copy, they're all going to get answered. And so this strategy that you've adopted, John Vandenberg, is really a good one. I wanted to add one thing, because we sort of got sidetracked a little bit. Personally, I did 28 months. I think it was the right thing to do. At the time, I don't think there was as much evidence for doing 18 as there is today. But that said, everybody that I know that stopped early has really had an issue. And you're that much into it, if you can hang on and you can do the balance, that's what I would do if it were me. But there are other things maybe to play around with, as you've just heard. And I mean, you've got a great doc there, and maybe talk to him a little bit about playing around with the dose on abiraterone, or just staying on abiraterone for the last 6 months
Yeah.
and not doing another Lupron shot, but keeping the abiraterone. I mean, that might be a possibility. But he's going to listen to you because he's very smart. He's a good dog. You got a good one. And you've heard what some of the conversation has been on here today.
Well, some of the issues that I've had actually have been dealt with through these discussions with the group here, because I'm wearing one of these things now. The
right.
The hot flashes were killing me. You know, I wasn't able to sleep at night, and now it's like, it's great. These things really do work. I don't know how, but it works. So thank you for your comments. Appreciate it.
Okay, and Joe Gallo, you wanted to say something. Go ahead.
I just wanted to add that it's going to be a little while before we'll have any experience data within the group. But the Relugolix or Govix, the pill, the daily pill instead of Lupron, the studies showed that the recovery was extremely quick. In the tests that they did, it was a matter of weeks. Whether or not that's going to prove out to be the case, you know, I'm a long ways off before I'm thinking about that. But that's another alternative to, you know, get engaged with your guy, your GU med-onc with.
Right. I mean, Joe, that's a good point. Let's say you've got 6 months to go on this regime. Maybe you can do the last 6 months orally instead of 2 Lupron shots. And then once you go off, it should come back very quickly.
Yeah, the study showed that it came back very quickly as compared to the Lupron, which is influenced by a lot of things, including your age.
Yeah.
But
Okay.
I'm a long ways off before I'm going to be looking for a vacation.
Okay, we're about at the end here. Jeff Marchi, you had something. You want to bring that up, or is it okay?
Yeah, well, real quick. By the way, I asked about the other relatives having a genetic breast cancer. When I went to genetic counseling, or the woman, when she found my father had prostate cancer, that wasn't good enough. My aunt dying of breast cancer and her daughter dying of it, and then my grandfather dying of pancreatic, that convinced them they had to test me. But just my father alone was not enough. That's why I asked that. I just wanted to mention, I had came in a few months ago about my PSA jumping to doubling on abiraterone in a couple of months. It went from 1.0 to 2.2. And I checked with my G with Harstark, and she said I could get a PSMA PET scan anytime, just ask. But I figured I'd wait another month. My PSA went down to 1.6. The next month, last month, they went down to 1.5, and this month it went down to 1. So it can be real erratic, but apparently it's working. So
you have a very weird PSA history anyway, if I'm not mistaken. Isn't that right, Jeff?
Not too much. I really never went up, maybe 0.1 or 0.2 every month. But on abiraterone, yes, it's been a little crazy. You're right. Before that, it was pretty stable. But I just figured if somebody's worried about their PSA not going down, wait. I've been 1 year on it this month, so it does work.
I have a question for Jim Ward.
Go.
Jim, are you totally off? Are you totally on a holiday, or are you on a monotherapy?
I totally went off of all ADT 1 year ago. But before that, I was on Lupron. And abiraterone and prednisone.
And how are you monitoring yourself right now?
I get monthly labs.
Any scans at all, or no?
Yeah, I think I'm probably going to get them about every 6 months. I had scans in July, and they didn't show any progression. So I think we're just, we're probably on the verge of lining up some more scans at this point.
Awesome. Congratulations. That's great.
Thank
Enjoy
you.
the
I'll take
holiday.
it for now. Thank you.
Yeah, you bet.
I'd like to say one thing on this, and it's come up a couple of times this week with different people. If you make yourself crazy over your PSA, don't get a 3-digit PSA ultra sensitive reading when you're on a scan. Go to 2 decimal places or even 1 decimal place, because it isn't going to make much difference to your treatment. You're going to wait until it gets over 0.1. But you guys, you can make yourself crazy when you see it go from 0.001 to 0.003, and you're going to say, oh my God, it's gone up, it's tripled. It's not the same thing. This is a conversation we've had recently with Gary Peters and with Bruce Bochin. And I mean, if you have that mentality where it's not going to bother you much, fine. But if you're going to get very nervous, why not just get a less exact PSA scan? It's great for your mental health.
Yes, I agree.
Rick, you and I had that conversation, and I think I'm still doing the ultrasensitive PSA, but I don't drive myself crazy about it anymore just because Dr. Korn and I agreed on a number that would sort of be a trigger number for doing something different. And so in this case, it was 1.0. And so I'm more focused on just, hey, when I get there, fine, then we're going to do something different.
Okay,
guys. So
thanks for sharing, Jim Ward.
Cal, good luck tomorrow with your first chemo. You'll do fine. Usually chemo, you don't feel much until about the 3rd one. So relax, take it easy, and just do the best you can. Don't get too nervous. And Chick, this has been a steep learning curve. We realize, and many of us have been managing this disease, and there's probably been terminology and drugs and scan this and that that go right through your head. And, relax. You don't have to worry about a lot of this stuff right now. Just look for the right doctor. That's the first thing, and this will all make sense. Hopefully, maybe never, but down the road, perhaps. Okay. So
thanks a lot for the encouragement. Thank you.
I can second Peters. No, don't let chemo make you crazy.
Okay, and if anybody does speak to Jake, let us, send an email out with a chain. Let us know how he's doing and so forth, because we're all thinking about him for sure.
Well, something must be up because I left 2 messages and he normally picks up.
Right. So, we care about him. He's an integral part of this family for sure. Well, thank you very much, everybody. It's been an interesting meeting. We've gone around the block numerous times and different things, and it's I feel for all of you, and we're working with a lot here. But take care. Hopefully the new year will go by quickly and we'll be okay. That's my hope.
Good job, Peter. Good job tonight.
Yeah, thank you.
Great job.
Thanks, Peter. Good night, everyone.
Good night, everybody.
Good night.
Happy
Good
New
night.
Year.
Good night.
Rick, could you